Okay, well, good evening to everyone on this beautiful Thursday evening in early June. My name is Nikhil Gatnikar. I'm an interventional cardiology fellow at Loma Linda University Health in Southern California, and I have the privilege of serving as the Southern California ACC Fit Catalyst with my Northern California counterpart, Natalie from Stanford. Over the course of this past academic year, we've put together some programming with a lot of wonderful input from our California ACC Executive Committee, as well as our California Fit Committee, to build programming out to help fellows and attendings alike within the state of California learn about different clinical expertise and clinical practices that are taking place at different centers. We'd be remiss if we didn't recognize the contributions of Dr. Hilliard, Dr. Rana, and Liana, as CEO of California ACC, for empowering us with time, resources, whether it's Zoom or their marketing expertise, in order to create this program for you all. We have an excellent program this evening. 3 speakers doing, I think, very unique things, things that even I, from a large medical center, haven't had any exposure to in the past. And I think that the expertise and the insight they'll be able to share tonight will allow us to learn about their day-to-day and be better clinicians. There's kind of going forward. So without further ado, just to kind of get things moving, we have Dr. Gregory Saja. Apologize.
That's right.
He's a staff cardiologist at Naval Medical Center in San Diego. He is a recent graduate, actually, from the Naval Medical Fellowship Program, and he and some of his colleagues are actually some of the inaugural members of joining our FIT committee this year. So we're incredibly grateful for him to offer time this evening and share their perspective of clinical cardiology within the armed forces. I'll turn the floor over to you.
All right. Thank you very much. Appreciate it. All right, I think you need to enable screen sharing for me.
Oh, sure. Sorry about that.
No sweat.
Okay, you should be able to share now.
All right, I think we are in business. All right, so my name is Greg Saja. I'm a staff cardiologist at Naval Medical Center San Diego. We're a pretty small center, so even though I'm not an interventional cardiologist yet, I'm actually starting training in 2024. I'm also dual hatted as a director of the Cardiac Catheterization Laboratory. It means I get to push a lot of paperwork. But I'm here today to talk to you about what Navy cardiology is all about. My goal at the end of our time together, not necessarily recruit all y'all into Navy cardiology. You're too far along in your career. But my hope is that you have a little bit more understanding about what we do. And if you know anybody who's interested in Navy cardiology, maybe you can kind of share with them what we do. Folks are earlier on in their training. So just a little bit of time to talk about myself, because I've been asked to do that. It's not something I enjoy doing, but I do enjoy showing this cool picture of me sitting on the flight line in Hawaii. So a lot of us in Navy cardiology kind of take circuitous routes to our career. Navy asks us to do, interesting and different things, maybe before we get the specialty of our choice. So I did a year of internship at Walter Reed, and then got sent to Pensacola, Florida to get trained as a flight surgeon. That means I'm basically a primary care physician for pilots. I did that job for 3 years, got to go on 2 deployments to the Western Pacific, so Guam, Korea, Hawaii, and a lot of time in Japan, and got to spend some time flying around in the back of an F-18, which is a pretty fun ride. After my 3 years, I came back, finished my residency, then came out to San Diego, did a year as a staff intern, staff tour as an internist, and from there, only finally after kind of paying my dues did I get picked up to do fellowship in cardiology. So kind of roundabout route, a lot of experiences on the way, learned a lot about leadership, and that's one of the things I think makes me and my colleague pretty unique, is that we get to kind of do these sort of interesting jobs on our way through our training. And then one other way I want to toot my own horn here. This is me. I'll say this is the second biggest crew I've had to perform in front of in the last couple of months. This is me last month finishing a solid second place on Jeopardy. So I can't give any advice about how to win, but if you want any advice about how to get onto the Alex Trebek stage, maybe stick around afterwards and I can share that with y'all. But enough about me. I'm here to talk about Navy cardiology. So we'll start off with a case to kind of prime everybody's brain about what we think about when we have patients come through our active duty clinic. This is a clinic that we see basically once a week, every Tuesday morning. So our first patient is a 39-year-old man. He's a Marine Corps Lieutenant Colonel, and he's an F-35 pilot. He comes in for an FAA physical, so he's actually trying to get out of the military and become a civilian pilot. So he's doing a physical for the FAA. His flight surgeon notices that there's several PVCs on his EKG. Flight surgeon performs a kind of basic workup that's unremarkable, orders a 48-hour Holter monitor, and then refers the patient to our clinic. If there's any, EP fanboys out there, fangirls out there, this is his EKG when he comes into our clinic. So he comes to our clinic and we put him through the ringer. So by the time he shows up in our clinic, we already have his Holter monitor, which shows a PVC burden of 26%. We put him on the treadmill. He does awesome, no surprise. He's a Marine Corps colonel. He does 17 METs. His PVCs go away. He has no ischemic changes. And his PVCs result of exercise. And he has a totally normal echocardiogram. So hopefully we do have a little bit of time to get some audience response. So if anybody, I'd like to try this out. If you guys go to this, I'm trying to figure out how to get this to work. The screen sharing paused. Share. Here we go. All right. If anybody could pull out a mobile device and go to this URL, I just wanted to kind of pull the audience. I don't expect you guys to be experts in military cardiology, but I would like you guys to chime in and think about what you would do for this patient. So if you go to polluv.com/Gregory Saja 545, there should be a opportunity for some audience response here. So just to summarize, 39-year-old Lieutenant Colonel, feeling great, incidentally discovered PVCs, 26% PVC burden. PVCs went away on the treadmill, normal echocardiogram. We gave you 3 choices. You can say, shake his hand and say, all right, you're good to go. You can go back on flight status. You can refer the patient for an ablation. Or you can put the patient on a beta blocker and return the patient to flight status. I'll let you guys chew on that for a minute. While I move on here. Let's talk about what makes Navy cardiology special. And in my mind, there's a couple of things that make us kind of unique. First of all, every Marine and sailor is an athlete. We like to say that all Navy cardiology is sports cardiology because all of our patients are athletes. All of our sailors have basic physical fitness standards that they have to meet to stay in service. But some go even above and beyond that. We take care of Marines, right? They go to bad places, they storm beaches. They have to be incredibly physically fit to do what they do. And then especially here in San Diego, we have our SEAL population as well. And these guys are essentially professional athletes, right? These guys are operating at the peak physical performance. What's important when you're taking care of these patients is that average cardiovascular fitness won't cut it. Our patients need to have superior cardiovascular fitness and cardiovascular performance, and even the minor problems can turn into big problems. We've had at least one patient come in for chest pain. We put him on a treadmill, and he didn't develop any EKG changes until he reached stage 7 of Bruce protocol. And that's important for our patients because our patients need to be able to perform at that level of physical fitness. We took him to the cath lab and he did have obstructive disease. So our patients need to perform above and beyond maybe the average patient who comes through a cardiology clinic. Anytime, anywhere, our patients go to very remote places. They go to random atolls in the middle of the Indian Ocean. This is Diego Garcia. We have a base out there. They float out in the middle of the ocean in an aircraft carrier. They deploy to forward bases. These are places where medical resources are scarce. And if a serious cardiovascular problem happens, usually the answer is to medevac that patient out of their environment into a place where they can receive care. So they are in danger while they're en route until they can receive definitive care. And then not only is the patient in danger, but you potentially compromise the mission because now, the carrier, the base, wherever you are, is down one sailor Marine because they had a problem that you didn't anticipate or didn't take care of appropriately ahead of time. And then we have patients who operate at the extremes of physiology. We take care of pilots who are subjected to serious G-forces. We have divers who have to, dive and are exposed to several atmospheres of pressure. We have to know how the heart responds to these sort of situations. And they're in high-risk environments. If something goes wrong to your pilot, it can have potentially disastrous effects, not only for the pilot, but for the mission and for bystanders. So we're operating in basically a zero failure environment. And sometimes that does affect our decision-making. So back to our clinic and our patients. Our patients come from all over the place. We certainly have several bases here in San Diego that our patients come from. We have Marine Corps Recruit Depot. We have the Navy base down 32nd Street, Naval Air Station North Island, Marine Corps Air Station Miramar. So we certainly have a lot of patients that we have to take care in our local area, but we see patients throughout Southern California. We have Marines coming all the way from Yuma, Arizona. We have Marines coming from the desert, their training facility in 29 Palms. We have Army folks and Marines coming all the way from Barstow, California. So our goal when they come into our clinic is to do things efficiently and try to get everything taken care of in one visit. So there's nothing magic about our setup. We have usually one physician and one fellow who's seen our patients. We have corpsmen, and these are the Navy's equivalent of medics who are checking in our patients and taking vitals and getting EKGs. And then we have one ultrasonographer who's doing all of our echoes. We have a PA and a technician in our treadmill room running all of our treadmills. And I have to single out Martin here by name because he does like a tremendous job taking care of all the monitors. It's a very, very hard job. And our patients, especially in active duty clinic, often require a lot of ambulatory heart monitors. And our goal is to provide comprehensive care and definitive disposition for all active duty service members with known or suspected cardiovascular disorders. So the ideal state is that all of our sailors are fit for full duty and worldwide deployable. Well, what does fit for full duty mean? Well, there's no surprise, a lot of regulations that tell us what fit for full duty is supposed to look like, right? So the DoD has their instructions about what the medical standards are for folks entering the service and who can stay in the service. Navy went above and beyond. They said, well, we want to have our own regulations about who can stay in the service. We have regulations about when to separate patients from the Navy, and that includes specific cardiovascular recommendations. Dive personnel are held to a very specific set of standards. Our aviation personnel are held to very specific standards. So it can be a very confusing alphabet soup of regulations. But really what it boils down to is, can you do your job? Can you do the thing that the Navy has hired you to do? Or is your medical problem or your cardiovascular problem getting in the way? If you can't do your job, there's a couple of not fit for full duty statuses that we put folks on, and it really depends on how long you can be how long we expect you to be out for, how long it will be until you return to the fight. For folks who we think can get back to full duty status in less than 3 months, we put them on light duty. For folks who we think will take a little bit longer, we have a duty status called limited duty. And if we think it's going to take longer than 12 months, that's when the Navy tells us to refer folks to physical evaluation board. What a physical evaluation board is basically it's a collection of both medical providers and regular Navy line officers who get in a room together and kind of review all the facts and folks who have serious medical conditions. On the one hand, they have to consider the medical facts and how disabled the patient's going to be, what the patient's restrictions are. But then on the other hand, they also have to consider what this particular patient, this particular service member contributes to the Navy. So there may be situations where folks have serious cardiovascular problems, but they're so essential to the mission that the line folks are going to say, we need to keep this person in the Navy, and we're willing to accept the fact that this person has cardiovascular disease and potentially has restrictions on what he can do or where he can go. But he's so essential to us that we need to keep him. Sometimes that's not the case, and the opposite happens. The board says, yeah, this patient's restrictions are really too onerous, and we can replace this patient or the service member. They would refer the patient to the VA for a disability evaluation and separate them from the service. So a physical evaluation board kind of takes all the facts and figures out really what each patient brings to the Navy and whether medical restrictions will prevent them from contributing in a way that the Navy wants them to contribute. So let's get back to our poll question, see what everybody said here. All right, so PVC ablation. So that's what I thought at first, but we actually came to a different decision after kind of reviewing all the facts in the case. So I was a flight surgeon. I like being a flight surgeon because there was very specific about what pilots can or can't do, and what exactly needs to happen for pilots to be returned to flight status when they have a medical problem. And our regulations are very specific in regards to what to do for a variety of cardiovascular problems. So essentially what it tells us to do in folks who have PVCs is to do a stress test, to do an echocardiogram. And if we think that the patient is worldwide deployable and the patient can continue to fly, then they can be returned to flight status. And this patient was asymptomatic. He was doing well. He's continuing to exercise. He was totally asymptomatic. So we thought it would be reasonable to return to flight status without any medications or a PVC ablation. Now, we are going to have some restrictions. His waiver is going to say that he has to see us every year. We're probably going to keep a close eye on his EF to make sure that he doesn't have a PVC-induced cardiomyopathy. But we think he can continue to fly. So we've recommended a waiver for this patient. All right, second case, we have a 25-year-old man. He's a Master at Arms, so he's an enlisted sailor. He's basically military police. He comes to an ER visit with a mental health problem, but he is incidentally discovered to have WPW pattern on his EKG. He is referred to our clinic where he denies palpitation, but reports essentially atypical chest pain. So here's his EKG with his delta wave, again, for the EP fans in the house. Again, we put him through the wash pretty quickly. We do everything, in the same day. We run him on the treadmill. He does 11.2 METs. His delta wave does not go away with exercise. We do an echocardiogram, which is unremarkable. And then before he goes out the door, we literally affix the Holter monitor to him, and he sends it back 14 days later, and no arrhythmias are seen. All right, so new question. What do you do for this patient? Do you return to full duty, or do you refer him for an EP study? All right, we have a vote for returning patient to full duty. What we did for this patient was actually to refer him for EP study. It was probably the right thing to do anyway, right? Because he has this delta pattern that we couldn't make go away with exercise. And kind of regardless what the patients do, what he does for Navy, we had to prove that this pathway couldn't participate in any sort of lethal arrhythmia. So we did take him for an EP study where we proved that it was a pretty wimpy pathway. We weren't able to induce any SVT. We found the right side of the accessory pathway. It was right next to the AV node, so it would have been a high-risk affair to try to ablate it. So we really didn't try. Couldn't participate in an atrial arrhythmia, high risk to ablate. We left it alone. But one overarching theme that we often see in military cardiology and Navy cardiology is that we are probably a little bit more aggressive at proving to other doctors and to line officers that patients are good to go, right? That we can send them to harm's way and they're not going to go into AFib while they're deployed in the deployed status. We're more aggressive probably at treating obstructive coronary disease with catheterization up front as opposed with medical therapy, because our line officers are folks who drive ships and fly planes. They want durable solutions, and sometimes that does lead towards more procedures in our patients. In fact, our pilots, if they have WPW pattern of any sort, it requires an EP study, even if they're asymptomatic, even if their pathway goes away with exercise. All right, third case, a 47-year-old guy. He's a senior EOD specialist. So if you guys have watched The Hurt Locker, that's what he does. But he's in the Navy, so he does like even more hardcore. He jumps out of airplanes, he dives and disarms mines. This is like a special operations guy. He comes to emergency department with chest pain. He's found out that he has AFib with RVR. He has a TE and a cardioversion, and then gets referred to active duty clinic. When I see him in clinic, he's still in atrial fibrillation with a heart rate in the 70s. He says he feels like $1 million. He's exercising every single day and doesn't have any symptoms. We do a workup to include an echocardiogram, which basically shows a big left atrium, a CT scan that shows some non-obstructive coronary artery disease. The question that we have to answer now is, what do you do? Do you offer a rate control strategy, a rhythm control strategy, PVI? So we jointly decided to go for a rhythm control strategy. We put him on flecainide and diltiazem. We repeated the monitor. He still had a lot of atrial fibrillation. So we increased the dose of the flecainide, repeated the monitor, and now he has significantly less atrial fibrillation. And in my mind, I think that was good enough. But the question was, well, what do we have to do to get this guy back into all the things that he wants to do? Because he wants to continue to dive and jump out of airplanes and be a Master Chief EOD specialist. And I was a flight surgeon, and like I said earlier, we were very used to having a whole lot of prescribed regulations about what needs to happen before folks can go back to duty. I talked to our local dive specialist. Like, no, you just got to write a statement saying that he's good to go. So I basically dropped this little note on his chart and said, he can do all the things that he needs to do without any restrictions. I don't anticipate he's going to be symptomatic. I don't think he's going to have any problems diving or jumping out of airplanes. I think he can do his job with minimal risk. And that was good enough. We'll jump to the last two cases since we're running a little bit low on time, and just shows maybe two similar patients that we treat a little bit differently. It shows basically that maybe highlights exactly what we think about military cardiology with how we take care of patients and what's acceptable with naval service and what's not. So this is a 27-year-old sonar technician. He's a couple years long in his service. A murmur was heard when he enlisted. And this condition was actually known about at the time of his enlistment, surprisingly, and he was still allowed to enlist in the Navy. He is a PT All-Star. He was a multi-sport athlete in high school and continues to exercise and do long distance exercise, and he wants to become a search and rescue swimmer. And we accepted a waiver for this patient to be an enlisted sailor despite his membranous VSD that you see here, because we didn't anticipate him having any problems anytime soon. He was certainly fit for full duty. He could do all the things that he needed to do to be a sonar technician or even be a search and rescue swimmer. He is going to require some follow-up over the course of his naval career. And because of that, there is a question in my mind: is this patient worldwide deployable? You're going to want to get an echo on this guy every year. He's at risk for aortic regurgitation because of his membranous VSD. You might have some qualms about sending him to an overseas duty station like Okinawa, or certainly Diego Garcia, or Europe. But at least while he's in the States, he's going to be able to do his job just fine and dandy. Compare that to this last case. This was a 19-year-old who just started their service in the Navy when they got involved in a motor vehicle accident, avulsed their mitral valve, and got a replacement with a pericardial tissue valve. So you see the echo after his surgery here. His pericardial tissue valve is working fine. There's no grading in there. And the patient asked me, "Hey, doc, can I stay in the military?" And this is a very similar looking patient to the patient that I just presented to you. He's back to exercise. He's feeling fine. He's asymptomatic. He says, "Hey, I can do everything that we need to do." The thing that we need to consider as Navy cardiologists is the long-term prognosis of this patient. We know that this tissue mitral valve is probably not going to last this patient for the entirety of his Navy career, especially if he wants to have a long Navy career. That means at some point in his career, he's probably going to need more interventions or surgery. So because of that, we referred him to a physical evaluation board where the decision is going to have to be made about whether it's worthwhile to keep this member in the service when we know that this valve is probably going to need more intervention in the future. And the likely answer is probably not. This is a new sailor, right? He just got trained. There's probably somebody down the pipeline who can do his job. So unfortunately, and it pained me to say it, that even though he wanted to stay in the military and was feeling great now, we need to think about the organization as a whole and refer this patient for disability evaluation so he can get his VA rating and get his care outside our system. All right, so that's all I have. Thank you, everybody, for joining my talk. Appreciate it.
Thank you so much for that really insightful and wonderful part of education for us tonight. Yeah, I think a lot of people don't necessarily understand what flight surgeon may be, or what different roles some of our armed service members may be performing on a daily basis, and necessarily place the clinical context of palpitations or chest pain or anything else into what they have to endure on a day-to-day basis. So I think your anecdotes that you shared and the patient synopses are tremendous to help us understand some more things as to how to treat somebody that's a little different maybe than the typical patient that rolls into a clinic that many of us may see. So I thank you again for your time this evening. And what we'll do is, if there's any questions, you can place them in the chat from our group. And if so, if you'd like to respond to them, that's fine. Unless there's any burning questions now, we can delay. If not, then we can share those responses to the group later via chat or email. So thanks again for your time this evening.
Yeah, appreciate it. Thanks for having me.
Of course. All right, so we're going to move on now, and we'll move to Dr. Vedantam. He's an associate professor with expertise in channelopathies and genetic diseases at University of California in San Francisco. I'd like to thank my Northern California counterparts for getting him involved in today's lecture. He's a physician scientist and clinical cardiac electrophysiologist at UCSF. His lab focuses on arrhythmias and genetic disorders of heart rhythm, using a variety of basic research approaches, and clinical practice blends procedural electrophysiology with inherited cardiovascular disease. I think this is an extraordinarily interesting topic, and I'm so thankful that you've offered your time this evening to educate us as a global group in the state of California. So without further ado, I'd like to turn the Zoom floor over to you. You're a co-host, so you should be able to share your slides, and we will go from there.
Great. Thanks for having me. Can everyone hear me?
Yeah, perfect.
Great. So I'm here with Emily Higgs, who's a genetic counselor in our group, and I'm going to try to make my presentation relatively brief so that she has some time as well to go over her role, because one of the topics I'll harp on today is that cardiovascular genetics is a multidisciplinary and interdisciplinary specialty or subspecialty, and it involves providers with different types of expertise. So no one provider really can handle all of this stuff from the handle everything that kind of comes into cardiovascular genetics clinic. So with that, I have a few slides that are really mainly just bulleted lists of things that we think about in cardiovascular genetics clinic. So just to start, why do we actually need cardiovascular genetic centers or sort of integrated places for patients with genetic or inherited cardiovascular disease to come? Sorry, one second. So first, one thing is there's been a rapid expansion in our knowledge on Mendelian diseases, and we've discovered that a lot of people whom we used to categorize as having idiopathic forms of cardiovascular disease, or even forms of cardiovascular disease that we've attributed to other factors. So for example, pregnancy-induced cardiomyopathy, various other things. Many of them actually carry deleterious mutations in genes that are important for cell biology of cardiomyocytes. Now that we know that many of those people have those mutations, it's important to identify them, treat them accordingly, screen their family members, et cetera. And along those lines, as knowledge in this area has grown, we now have management strategies that are not just based on the phenotype, meaning, okay, you have heart failure, so you get on a very particular cocktail, but in some instances, there are genotype-specific management strategies where, for example, if you have a mutation in one particular gene, you might need a defibrillator for primary prevention, even though your EF isn't really that low. Whereas we know if you have a mutation in some other gene or you are gene elusive, maybe that isn't necessary. Another factor is the barrier to testing for genetic or inherited cardiovascular disease has gone way down in recent years. Whereas it used to be a big deal to get approval to send a genetic test for somebody, now it's really, really cheap. I mean, even whole genomes in some instances can be purchased for a few $100s. So it's now pretty cheap to get this sort of data and information. And, along those lines, it used to be that, with expansive testing approaches, like looking at whole exomes or whole genomes, we didn't know what to do with that kind of data. But we're seeing now as knowledge has improved and analytical tools have expanded, we're able to make the diagnosis more frequently with these expansive testing modalities. And as things move forward on the horizon, there'll be more predictive testing for people who are asymptomatic, personalized genomics, things like polygenic risk scores, et cetera, et cetera. So these are all reasons to think about incorporating cardiovascular genetics into your practice, whether it's referring to an integrated center or ideally becoming involved with one if that's your interest. So what's the scope? So the way that these clinical centers operate. So the first thing to know is it's multidisciplinary and multi-specialty. So in our center, we work very, very closely with genetic counselors, with specialists across cardiovascular medicine. So very commonly, patients with a particular mutation will need a heart failure specialist, an EP doctor oftentimes. Sometimes patients with familial hyperlipidemia might need an endocrinologist, as well as a preventive cardiologist, et cetera, et cetera. These clinics tend to be referral-based, and so they're communication intensive. There's a lot of communication behind the scenes between different subspecialists, between genetic counselors and the cardiology providers, as well as with the patients and their families. And then there's a really kind of fun and unusual aspect of this sort of clinic that involves just basic detective work. And I'll get into that a little bit as this presentation goes on, but you have to, sometimes you get a genetic test result, it's not so obvious how to interpret it, and you really have to dive into the literature and try to understand what might this mutation be doing? Does it fit with the patient's phenotype? Sometimes patients have really old records that are extremely important and relevant, like, oh yeah, I'm 35 years old, but I had a sibling who died at the age of 7 in some other country. And yes, there are some records, some medical records, that we have from before when they passed, but I don't know, we don't have them on us now. And sometimes, if you have someone who can do the legwork and get those records, it's extremely useful and important. The other aspect of an integrated center, and this is really central to the area of cardiovascular genetics, is research. The two things are inseparable. It's not just, clinical care, partly because this is an evolving specialty and there's, knowledge is advancing very, very rapidly. So in order for us to do the best for our patients, really, an integrated center should be involved in registries. So patients with rare genotypes, we should pool them across centers around the country, and a lot of time, or even internationally, and a lot of times that happens. Also in a lot of these centers, there's grant-funded research, industry-sponsored research on sort of the latest therapies, investigator-initiated kind of pilot studies, everything under the sun, both bench research as well as clinical research. And at least at UCSF, we see these activities as really integrally kind of bound together. So, just to give you some examples, we've seen patients who have extremely unusual presentations. We might do an exome sequence and get a result where we have a mutation in an interesting gene. And, if it's interesting enough, we'll make a mouse with that mutation and characterize the mouse, or we'll derive cells that have that mutation and characterize those cells. And it both because it teaches us something about the biology of the heart, but also because in the end, it can inform how we manage those patients, and we can give those patients some sense for whether how this rare mutation is connected with what they are experiencing. There's also a medical education component to these centers where we try to be involved in educating clinicians with everything that's going on. The area, as I said, is rapidly evolving, and so it's really important to try to keep our colleagues abreast of the latest developments so that they know when to refer patients for genetic testing. And then there's an aspect of community outreach as well, to try to, both to help educate families who have these mutations, but also to try to, get people who might not otherwise be reached into the clinic to be tested when it's indicated. And I'll just go through this quickly, but, just for everyone, I'm just paging through this quickly in the interest of time, but essentially, these are really the disease areas where we will typically get referrals for genetic investigation. So, the standard things like HCM, DCM, arrhythmogenic cardiomyopathy, channelopathies, but even things like family history of unexplained sudden death. There's a lot of people with vascular and aortic phenotypes. And lately, even congenital heart disease, the yield of genetic testing has been increasing, and there are some systemic diseases where we get involved as well. So it's actually a huge number of conditions that it encompasses a lot of patients. And so usually the way we operate is we have a clinical lead in each of these areas, some clinician within the broader center who's an expert in each one of these areas, and we kind of come together and manage patients together. And so just to give you an example, at our center, we get referrals directly to a genetic counselor or directly to a specialty provider. And, we actually have about 3.5 genetic counselor full-time equivalents at any given time. Each of our patients will get a visit with a clinician, the clinician cardiologist provider, as well as a pre-test and a post-test genetic counseling visit. And our current capacity is around 500 patients per year in our center, but probably we could expand a little bit from there. And the way we operate, and I think a lot of centers operate this way as well, we do mostly panel testing. So we test for known causes of the patient's phenotype, but then for any test that's anything other than obviously positive or obviously negative, we have a case conference and we discuss the results at a weekly conference. And as a group, we come together with sort of an adjudication of whether the patient's genetic findings explain their phenotype, and we chart a path forward, sort of like a tumor board in a way, but maybe something like that, some sort of multidisciplinary conference. And we get referrals from inside the institution and from the outside. And on occasion, as I said, we'll do a very advanced testing for selected patients. Those will be whole exomes, whole genomes, things like that. So lastly, what I want to do before turning the floor over to Emily, I want to just highlight what I consider to be some of the challenges going forward in cardiovascular genetics, areas where we need newly minted fellows to kind of get involved to help move the field forward. So one is identification and referral of patients. So I think broadly speaking, there's probably under-testing out there in the world. A lot of patients who probably should get genetic testing don't. So I can think of many examples. So, we used to talk about something called lone AFib, right? Somebody under the age of 60 who presents with AFib in the absence of any other cardiovascular disease. Now we know that 10 or 15% of those patients, maybe more, will have mutations in titin, just as an example, that are pathogenic. And so, people who have unexplained cardiovascular disease, especially at a young age, need to be tested. And I think one of the other things that is a challenge in getting patients in, and I'll touch on this later in the slide, is the phenomenon of variable penetrance, variable expressivity. So very often you'll see a patient with early onset cardiovascular disease, and you'll say, well, there's no family history. I'm not going to worry that this is genetic, but you don't need a family history to have an inherited cardiovascular condition. So sometimes patients with a mutation may have a disease caused by the mutation, but a family member with the very same mutation may be phenotypically fine. So this sort of goes along with the first one. One of the other challenges is cascade screening and identifying patients at risk. So this is when we see a patient who has a cardiovascular phenotype and a genetic finding, we need to identify all first-degree family members who might also carry that mutation. And then from there, you have to cascade out. So you can imagine you might test someone and find out, well, okay, this patient has a mutation, they have 2 kids, we have to test both of those, but they have 3 siblings, we got to test them. The siblings each have kids, and we got to test them, and then their parents, and then the aunts and uncles, and pretty soon everything just starts cascading from there. And so it is a challenge, and it involves a fair amount of effort to identify everyone at risk and make sure that they get attention. And then there's also longitudinal management and care transitions to make sure that, oftentimes these patients have rare diagnoses, they need very particular precautions. And so that has to ideally go with them in their medical record wherever they go, even after they leave sort of the area or they leave our catchment area. And also very often we'll get patients referred from pediatrics who come to adult medicine. And so that care transition also has to be negotiated. And so we are pretty well integrated with our pediatrician colleagues here at UCSF, but in general, that's another area that kind of needs to happen seamlessly for these people. I talked about variable penetrance and expressivity as a major challenge sometimes in getting patients tested and then in helping patients interpret the results of testing. Very often, I think the understanding of genetics is limited even among our cardiovascular physician colleagues, let alone among the population at large, where people will imagine if I have a mutation, then my children have a 50-50 chance of having it. And why is it that they have it, but they don't have the disease? Or why is it that they have the disease, but they don't have, it gets very complicated to try to explain the principles to patients. And then probably the single biggest clinical conundrum that we get is what we like to call a VUS problem, or variants of unknown significance. So as you probably know, we all differ from each other basically genetically. 1 in every 1,000 base pairs or so in our genome differs on average from each other. And we have 3 billion base pairs. So it's about 1 million differences on average between 2 people, on the order of 1 million. And very often people have very rare variants. And so we test for 100 genes and to try to explain a phenotype, and we see a variant that we've never seen before or that's very, very rare, and we don't know whether it causes a disease or not. So we're sort of left in this limbo situation where we do a lot of detective work, we think about the mutation, but in the end, it can be very hard to sort out whether it's causing the disease or not. And so this obviously causes a fair amount of distress for patients as well as us, because we're sort of left telling them, well, maybe this is your problem, maybe it isn't. Let's follow you closely and see what happens and wait for more data. Another big challenge, and maybe an opportunity on the horizon, is trying to get at common diseases. So things like hypertension, garden variety high cholesterol, garden variety coronary disease, garden variety arrhythmias. We know that a lot of those things have a heritable component, but we don't really have ways to tackle the heritable component of common diseases yet. We have a sense for how genetic variation might lead to those, but using that data prognostically, figuring out how to use it to guide treatment is going to be one of the major challenges in cardiovascular medicine in the next couple of decades. And I guarantee for all the fellows, this is going to be something that you're going to see probably rising in importance throughout your career. So just to underscore that, and this is my last slide, this is a graph that you'll see all the time, wherever you go, probably anytime you see a talk on genetics. But essentially, most genetics, I hope you can see my little arrow, but most genetics up to now has been in this area, right? Where you have these huge effect sizes, right? Like, loss of function of an ion channel that causes long QT syndrome, highly penetrant, let's say. It's a single gene, and you see these families, and you'll have a 3-generation pedigree, everybody's affected. That's up here, huge effect size, big phenotype, and a single gene. At the other end of the spectrum is stuff like hypertension, like half the population has it, and it's a result of like hundreds and hundreds of inherited variants, that each of which have a very small effect size. That's at this end. So right now, most of what we do is at this end, and we're trying to move all of cardiovascular genetics so that we can encompass more and more of this whole graph. So we can try to help our patients, both the ones with rare diseases and even the ones with common diseases. So with that, what I'm going to do is turn it over to Emily, who's going to do and orient you to the role of the genetic counselor in the clinic and give you a case presentation as well.
Wonderful. Thank you so much.
Sure.
And last but not least, so you've already done the partial introduction for me, so I appreciate that. Emily, we will turn the floor over to you. Emily Higgs is a genetic counselor at UCSF and has been gracious enough to share her time and expertise this evening to talk about the marriage between channelopathies, clinical cardiac electrophysiology, and genetic counseling, and how they kind of work together in order to talk to patients and families. So the floor is yours. Thank you.
Great. Thanks for having me. Does that look okay? You can see my slides.
We can.
Great. Okay. So I'll just start by kind of explaining what a genetic counselor is in case you haven't worked with a genetic counselor before or really come across that. So we have advanced training in medical genetics as well as counseling. And some of our key roles are really gathering a detailed family history and assessing that family history, interpreting genetic test results and in the context of clinical information about the patient and the family history. And the counseling part is mostly about supporting patients to make informed decisions, adapt to diagnoses, and to communicate information with their families. Genetic counseling appointments are typically an hour long. So there's usually sufficient time to really explore patients' concerns and tailor the session to really what their concerns are and what their understanding is. So I'll just walk through a case example to kind of illustrate some of what we do in the genetics clinic. So we saw a patient who was an 18-year-old male who was otherwise in excellent health until he had a sudden cardiac arrest while he was playing basketball. So the toxicology was negative. His workup also included an echo, ECG, MRI, EP study with a procainamide challenge. It was all unrevealing. So he got an ICD and device interrogation a couple months later showed no arrhythmias. And as an outpatient, he had a stress test, which showed he was mostly in bigeminy, but also had some poly-VT patterns. So here's the pedigree that was taken in clinic. So as you can see here with the arrow, this is the patient. And he had a sibling who died suddenly at the age of 10 while on a ride at an amusement park. His parents have not had any cardiovascular issues, but his mother has a sibling who died in his early 20s playing sport, and sibling who died at 1 year old, but the details weren't known. And this is a cousin of our patient who died at 15 playing sport. So since there are multiple sudden deaths at young ages across multiple generations, this makes us suspect that there could be a dominantly inherited genetic predisposition to sudden cardiac death. And the genetic counselor role in the clinic really is taking this level of detail of family history, typically 3 to 4 generation pedigree. We probably spend about 20 minutes of the hour appointment gathering this information. And we can also, as Vasanth mentioned, do a lot of the legwork in gathering family medical records or death certificates, autopsy reports to try and understand more and verify the family history. In this particular case, though, there weren't any autopsy reports available. So for this patient, we were a little bit suspicious of catecholaminergic polymorphic ventricular tachycardia, or CPVT. If you haven't heard of that, it's pretty rare genetic channelopathy. It usually presents in childhood or early adulthood. There's a high risk for life-threatening arrhythmias. And typically the baseline ECG is normal, and you see the characteristic polymorphic VT with catecholamine release during exercise. We also still couldn't rule out, though, a different autosomal dominant channelopathy, or less likely but possible a cardiomyopathy that was presenting with arrhythmia as the first sign. So one little comment I want to make about genetic testing is that it's not completely sensitive for most cardiovascular genetic conditions. So a negative genetic test result doesn't always rule out a clinical diagnosis. And that's why it's really important for us to have the multidisciplinary clinic where we can pair the genetic testing interpretation with really careful clinical phenotyping. So for this patient, we ordered a panel of arrhythmia and cardiomyopathy genes. We typically go broad with genetic testing, and that's a common panel that we order. This is the picture of the buccal swab kit that gets mailed to patients, so it's very easy to do remotely if they're not coming in for an appointment. And just to say a little bit about the genetic test results. So this is what came up. So pathogenic variants in the RYR2 gene cause CPVT. So that was the gene that we were suspecting. It's the ryanodine receptor, which is part of the calcium channel. And so we never take the lab report at face value. Our clinic's practice is to really assess each variant carefully in the context of the clinical presentation of family history. So we go back to the primary data about the variant and consider that in detail. So you can see that the lab classified it as a variant of uncertain significance. Vasanth said the VUS problem. So when we look at the primary data about this variant, we can see it's in a hot spot in this gene. So variants in that region are typically pathogenic. It's very rare. It's absent from the general population based on the database we use. It's not been reported in patients in the medical literature before, and it's not been reported by other labs in the ClinVar database. We also sometimes ask the testing lab if they can share any more internal data about if they've seen it in other patients before, but they hadn't seen this one before, so it's rare. So that all led us to believe that although we couldn't be definitive yet that this was the cause of the patient's presentation, we were pretty suspicious and thinking this is likely the cause. So in the genetics clinic, we really use a family-based approach. And we can use information about how a variant segregates with disease in the family to help us interpret the pathogenicity of the variant. And in this case, the patient's mother was found to have the variant, which is consistent with our hypothesis that it explains the maternal family history. Although Vasant mentioned one of the issues is that a lot of these cardiovascular genetic conditions can have incomplete penetrance. So this patient's mother and sister both came in for an evaluation and both have the variant but don't have any clinical features of CPVT. So either that means maybe the variant is not the explanation of the history, or we're kind of thinking that it could just be incomplete penetrance in the family members. And as Vasant mentioned, our clinic is really closely linked with our research program. And so via one of our collaborations, we can actually get patient-derived iPSCs. And that's what we're trying to do for this patient so that we can do some functional analysis of the patient's cells to try and understand this variant a little bit more. And another thing we always do in the genetics clinic is provide the patient with advice for cardiac surveillance for their family members, because one of our main goals really is prevention or early detection in the kind of wider family. And we also tend to provide resources and support for the patient in how to effectively share this information with their family members. So that's an overview of a kind of more or less typical case in the cardiovascular genetics clinic, and just put my email there in case, you know, I'm happy to be contacted for any genetics related questions.
Wonderful. Thank you so much. I really think your explanation of the partnership you have is tantamount. And of course, with the expertise in a clinical center like UCSF and large centers that have geneticists available, it allows a lot of us to understand more about what should be done to interrogate kind of these processes that family members may know about or simply may not know about. So thank you for sharing your information there with all of us. I'm just reviewing our chat really quickly to see if there's any questions that were posted, and I haven't seen any. Are there any members from the audience with any specific questions for either one of our three panelists this evening?
Yeah, I have a question. Hey, this is Natalie. Sorry, I missed a little bit of the beginning. But I really appreciated Emily's portion of the talk and really appreciate the value of genetic counselors in our clinics. I was wondering how you approach repeat genetic testing. Is there, you know, every 5 years, a certain number of years, do you repeat? Do you expect the panels to change periodically? What kind of determines that decision?
Yeah, we typically do encourage patients to come back to the genetics clinic every several years for an update. Sometimes there is updated genetic testing because a new gene's been added to a panel, or potentially the technology's improved slightly, so it's worth repeating the testing. Or other times we might not be running another test, but like reviewing someone's variant of uncertain significance and seeing if there's actually more data available to help us interpret the meaning of that. But yeah, I'd say every 3 or 5 years is a good kind of check-in point as a rough rule of thumb.
And fortunately for us, sometimes, you know, at least within Vitae, if they reclassify a variant of unknown significance and it's in their database as a test that we sent, they will notify us directly that, hey, this test on your patient, you know, 2 years ago that we called a variant of unknown significance is now likely path, just letting you know in case you want to recontact the patient, which is actually pretty helpful. Not that we don't have our own database, but still, it's hard to, you know, it's just not practical to like look through PubMed every single day for a paper that might or might exist that was just published having your exact variant in it. So that service is actually quite helpful.
Thank you. That's super helpful. And I might have missed this at the beginning of the talk, but is the Invitae panel like a US based database, or is it international?
You mean, do they get their, I assume most of their cases come from within the United States. I would be surprised if they get a lot internationally. You're thinking, does that limit their ability to call variants for people with different ancestries, or?
Yeah, exactly. Yep.
Yeah. No, I mean, the ancestry problem is a massive problem in all genetic medicine everywhere, basically. That is an issue. And I think for us, especially in the Bay Area, which has a pretty unique patient population in terms of ancestry. I mean, we have people from, as you can imagine, from everywhere. So we get tons of variants of unknown significance. And we always wonder how much of that is just related to the fact that, you know, there aren't that many patients with their ancestries that are represented in databases, unfortunately. So there's a lot of hand-wringing and thinking about how to deal with that particular issue, but I'm not aware of any definitive solution on the horizon just yet, short of more sequencing of more people.
Awesome. Thank you.
All right, any other questions from the audience? Okay, so to be sensitive to everybody's time, it's unbelievable. It's already been an hour. A huge thank you to our three panelists this evening. Your expertise and the time that you're willing to share with us is greatly appreciated. I've taken away many useful items that I think will improve my clinical practice. And I hope that the people that were able to join and those that will be able to watch our recorded session will also gain some very insightful things that they can take back to their own patients and improve the cardiovascular care in their communities. I want to thank you all for your time this evening, and hope you all have a wonderful rest of your day. Thanks again, everybody.
Thank you. Thanks for the invitation.